Mitsis.
Dear Chairman, dear colleagues, greetings from Nicosia, from Cyprus. First of all, I would like to thank the organizing committee for inviting me to this very interesting conference. Without losing any more time, let's proceed with the topic, with the presentation, which is about the devices we use for transcatheter closure of ASD, PFO, and LAA. Let's explore the similarities and the differences of the devices. PFO is the flap-like opening.
I cannot see your slides yet.
Oh, sorry. Okay, now should be. Can you see the slide now?
Yes, yes.
Apologies. Again, PFO, the flap-like opening without any loss of septal tissue. It's a quite common condition in about 25 to 30% of adult patients. And now we have robust evidence that it is not a benign condition. It can be associated with cryptogenic shock via paradoxical embolism. Over the last 10 years, there have been conducted 6 randomized control trials comparing the PFO percutaneous closure with medical therapy with very promising results. These RCTs have been used different devices, and let's have a deep view in the most common of them. Starting with the Amplager PFO occluder from Abbott. It consists of 2 nitinol wire mesh discs. The right disc is larger than the left disc, apart from the small device, the 18mm device. There are 5 devices that can cover all the anatomies, and of course the device is covered with Dacron that stimulate endothelization. We have the Figula PFO occluder from Occlutech. The difference of this device with the previous one is that the nitinol discs are covered with titanium, and this can minimize the nickel expose and can be suitable for patients with a nitinol allergy. Furthermore, this device is less traumatic as there is no hub in the left atrial side. Again, 5 available devices. And last, we have the Cardioform septal occluder from Gore. This is a non-self-centering double disc device. Again, 2 discs covered with PTFE and 5 available devices. This meta-analysis tried to explore the risk of stroke recurrence according to the device based on the previous randomized control trials. And as we can see, there is no much difference with regards to the risk of stroke. However, the risk of atrial fibrillation following the procedure, especially with the Gore devices, was elevated. This slide concludes these devices. Again, the Amplager PFO, we have the largest experience. However, it's a rigid device and maybe cannot be used in more complex anatomies. The Cardioform from septal occluder, a softer device. We have evidence, a lot of evidence and data. However, the question is the atrial fibrillation following the procedure. The Figula PFO occluder, which is, as we said, very useful for patients with nickel allergy. And finally, a new concept, the noble stitch, which is not a device, but this is a procedure where we put 2 stitches, one in the right side and one in the left side of the septum, and this is how we close the PFO. Let's proceed with the ASD. The ASD, as we know, is caused by abnormal embryonic development. More commonly, 80%, it is a secundum ASD, which is located in the fossa. And this can be completely asymptomatic, but sometimes, and if there is RV volume overload and with a QPQS more than 1.5 and there is no pacemaker, there should be a treatment for these patients. Surgery versus catheter closure, similar success, lower morbidity and lower hospital stay for patients treated with catheter intervention, but with higher re-interventions. Are all the ASD suitable for catheter intervention? No. Of course, the diameter of the ASD is the most important thing. There should be sufficient rim to facilitate the stability and the stable delivery of the device. And of course, the dimension of the total septal length should be no smaller than the left disc. The available devices, starting with the Amplager septal occluder, the most popular, and probably this device has been in the market almost 25 years with FDA approval since 2001. A device with nitinol again. All these are nitinol devices. Repositionable, recapsable device with 27 available sizes. The same company, Abbott, can provide also the cribriform occluder, which is suitable for patients with multiple fenestrations. And this is a non-self-centering device that, in this case, the two discs will cover the defects and not the waist. Gore has also the Cardioform ASD occluder, which is the self-centering version of the Gore septal occluder we saw earlier. There are 5 available sizes and can close defects from 8 to 35 millimeters. Occlutec provides the Occlutec Figula ASD occluder, similar to the PFO occluder from the same company. The cover with the titanium can be a suitable option for patients with nitinol allergy. There are 20 available sizes, and disadvantages the slightly larger delivery catheters. And finally, these two devices, the Seraflex from China and the Cocoon from Thailand, softer devices with less variety in sizes and larger seats. This meta-analysis tried to collect data from 12 non-randomized trials and registries, comparing the effectiveness of devices for ASD closure. There was no significant difference in acute device embolization, but the residual shunt was elevated when the device with the Helix device, which now I have to highlight is not anymore in the market. And this is a busy slide summarizing all this that we already discussed. I will finish with the devices that we use for the left atrial appendage occlusion. Dr. Gikas presented beautifully in the previous presentation the whole concept. And as we know, all the patients with non-valvular atrial fibrillation should be on anticoagulation. Some patients cannot tolerate or have contraindications or are in bleeding, elevating bleeding risk. So for these patients, the procedure is suitable. There are 3 randomized controlled trials so far comparing the concept of left atrial appendage occlusion with medical therapy. PROTECT-AF and PREVAIL, these randomized controlled trials compare the Watchman device, the first generation of Watchman device versus warfarin. The LAO was non-inferior, and PRAG 17 include the 2 devices, the Watchman and the first generation of the Amulet, ABC. And again, it was non-inferior. And this meta-analysis of these 3 randomized controlled trials showed that the ischemic stroke with the patients who were treated with OACs, where they had a better outcomes in regards with the ischemic stroke, but the favor for the patients treated with the closure devices, they have less hemorrhagic strokes and bleedings. What type of devices we use for LAA closure? three principles. So the devices that we are using as a plug. There is an endovascular delivery of a lobe in the neck of the LAA, and this is how we close the communication between of the LAA and the left atrium. The pacifier principle, apart from the lobe, which is delivered in the ostium of the LAA, there is also a disc that is used to seal the LA. And finally, the concept of ligation, which is more a surgical concept. Many devices available. We will focus only in these two that have FDA approval. The Watchman Flex device, which is the evolution of the Watchman 2.5 device. It's a self-expanding nitinol frame structure with 18 fixation barbs. Has received the approval from the FDA in 2020. Just to highlight that the previous Watchman device was the only one with FDA approval. And the Watchman Flex can be used to close LAAs with size from 17 to 31 millimeter. From the other point, we have the Amplatzer amulet from Abbott. This consists of a lobe and a disc. Approval from FDA in 2021. And it can be used to close a larger variety of sizes, starting from 11 to 31 millimeter. Both devices are recapturable, and the Amplatzer also can be used in more difficult anatomies. This is the evolution of the Watchman device, and for all of us who are Watchman operators, we can understand the correct choice of the delivery catheter. There are three catheters and with anterior curve, which is used for retroflex chicken wing LA anatomies. The double curve catheter, which is most commonly used for superior anterior directed LAAs, and the single curve for mid-level to inferior directed LAAs. And this is the Amplatzer amulet, as we said earlier, and the sizes of the device. We will finish with the two randomized control trials that try to compare head-to-head these two devices. The Amulet IDE randomized control trial compared Amulet with the first generation of Watchman with regards to the device-based LAA closure. And this is the 3 millimeters per device leaks that you heard earlier by Dr. Gikas. And the results showed that the Amulet LAA closure was better with regards the residual jet, and the primary safety endpoint rate was not inferior from this device in comparison with the Watchman. And the other randomized control trial is the Swiss Apero trial, Amulet versus Watchman Flex, the new version of the Watchman device, and some old Watchman 2.5 devices. Again, the 40-day LAA patency, more leaks for the Watchman device, but less major bleedings and no cardiac tamponades, and similar clinical outcomes in 40 days. And to conclude, and to summarize, large experience with both devices, CE marks and FDA approval for both devices, advantage of the Watchman, the new round ball design that is safer and you can maneuver safely in the LAA. And these patients, since they don't have the LA disc, they don't need for further time anticoagulants for the endothelialization. However, there is more often peri-device leak, and the Amplatzer amulet, a device that can close almost every LAA, and however, these patients need longer-term DAPT for the endothelialization, and the data shows more periprocedural bleeding and more procedural-related complications. Thank you very much for your attention.
Have time for questions. I would like to thank you all for attending this session.
Good night.